Hello friends, I'm Dr. Anurag Shrimal, Director Liver Transplant Surgery, now practicing at Mumbai. Welcome to our series of educational videos. Today I'm going to talk to you about living donor liver transplant, especially the donor surgery. Now, why do we need living donor liver transplant? Let's understand that first. Liver transplants can be done when somebody donates liver. It could be a family member donating a part of their liver, that's a living donor liver transplant, or you're on a wait list and you receive a liver from a brain dead donor. That's cadaver donor or disease donor liver transplant. The wait list for cadaver liver transplant is quite long in our country and there are not enough donations. So almost 30 to 50 or sometimes 70% of the patients who are actually the disease donor or cadaver donor wait list do not reach to a transplant. Now, why living donor liver transplant? Let's understand that. Okay, so one thing is that the number of organ donation in our country is low. The presentation of these diseases, sometimes they present to us at an advanced stage of cirrhosis, which is characterized by deep jaundice, ascites, repeated hospital admissions because of repeated infections, SBPs or other complications. Some of these patients develop hepatocellular carcinoma or HEC, a liver tumor, which is common in the patients with cirrhosis. And in all these situations, we are racing against time. Liver has got two very special properties as an organ. It's the largest organ in the body, and the two very special properties are liver reserve and liver regeneration. So reserve means a healthy individual donates 70% of his liver. The remaining 30% is able to maintain normal body functions of that individual. So that's the reserve in our liver. Regeneration. In a short span of time, which is as short as 6 weeks to 3 months, the remnant liver regrows. It regenerates in the 3 dimensions and reaches almost 90 to 95% of its actual size. Now, these two properties make it extremely safe for an individual to donate a part of their liver. So remember, living donor liver transplant is a gift of life from a near and dear one to his own family member. And that's where lies the special importance, and especially so in our country where the cadaveric organ donation rates are very low. It's a life-saving surgery being performed on a near and dear one as a gift of life. Now, the most important question that comes to my mind when we talk about living donor liver transplant is donor safety. And how do I ensure it? We evaluate the donor very, very thoroughly. The first phase is meeting the donor, understanding the donor, asking as well as clearing all their questions which are there in their mind about liver donation, explaining them the safety of this operation. Then we proceed with a thorough medical history and a thorough physical examination, including the height, weight, BMI, pulse, BP, oxygen saturation, etc. We do the phase 1 of evaluation, which is the blood tests, and it's a battery of blood tests, including your CBC, LFT, RFT, all the metabolic profiles, lipid profile, thyroid profile, HbA1c, fasting blood sugars, calcium, magnesium, phosphorus, liver function test, kidney function test, battery of tests. And this includes the viral markers, hepatitis B, C, HIV, hepatitis B core total antibody. Once we ensure that all the blood tests are normal and we are not dealing with any hidden illness or any derangement of liver function test, we proceed with the phase 2 of evaluation that involves CT scan. The first part of the CT scan is a plain CT scan without any contrast, and that gives a very good idea about the content of fat in the liver. The score is called as liver attenuation index. A normal index is between 5 to 15. 0 to 5 can be accepted, sometimes with some weight loss. And if the liver attenuation index is negative or less than 0, these patients themselves need to lose weight for their own fatty liver. So the next stage of donor evaluation is a contrast CT scan. And in layman's term, we study the liver quantity, quality and make. So what is quantity? That how much is the total liver volume? We draw an imaginary line working with the softwares on the computers where we will divide the liver. What is the amount of liver that will go to the recipient? What is the amount of liver that will remain in the donor's body? What is called as future liver remnant, and it should be at least 30%. The quality, which I discussed already, that is the liver too fatty. The make, how the blood vessels go through the liver. Are we able to divide them into 2 parts where both the parts can remain functional? How the bile duct anatomy is, and that we study with an MRI. And with that, we can very, very clearly tell you that is it safe for a donor to donate a part of their liver. We proceed then with the next phase, which is phase 3 of evaluation. Here, we do a complete evaluation for anesthesia fitness, is cardiopulmonary evaluation, which includes ECG, 2D echo, stress test, pulmonary function test. Our policy is to evaluate what is called as the thrombotic profile. So is there an increased tendency of blood clotting in any individual, and if so, how can we make sure that this person can safely donate a part of the liver? So this completes the medical evaluation of a donor. Subsequent to that, we have a DNA match, what is called as a kinship analysis, as well as the legal requirement, what is called as the local authorization committee or the DMER or the HAC hospital authorization committee meeting. After all this process is followed, then we can proceed with the actual surgery or the liver donation surgery. Then comes the day of surgery. So the donor is admitted a day prior. A basic set of investigations is repeated to ensure that all the parameters are within acceptable limits. On the day of surgery, there are two parallel operating rooms. In one operating room, the donor surgery is going on, and in the second operating room, the recipient surgery is going on. The donor surgery starts first. Our anesthesia team first comes into picture, where they give anesthesia to the donor, they secure lines, we position the donor, and once everything is ready, we paint and drape, and then we are ready for the incision. Donor surgery can be done in the conventional way, which is an open surgery, and now we do it only with a midline incision, a small midline incision which is around 8 to 10 centimeter, and it avoids cutting any muscles. The other option of doing donor surgery is a minimally invasive donor surgery or a robotic donor surgery. Again, in a robotic donor surgery, the robot gives a lot of precision as well as magnification, and here the liver is removed to an incision in the lower part of the belly, which is called as the phalansteal incision, and hence make it more cosmetic. In the donor surgery, we first inspect the liver, we dissect the important structures, and then we are ready to take a part of the liver out. We work together with the recipient surgery team and ensure that the two operations are running in tandem, and that once we remove the liver, it stays on the ice for the minimum duration or as short duration as possible, what is called as the cold ischemia time. We remove the liver, we flush all the blood so that no blood clots forms in the microcirculation. We flush all the clots, all the blood through it with special solution, and then we prepare the liver for implantation on the back table using fine microsurgical techniques. On the donor side, we close the cut ends of the blood vessels of the bile ducts after we retrieve the liver. After that, we secure hemostasis. We secure good stasis or good control of all the bile ducts so that there is no blood or bile which is leaking from the capillaries or from the bile ducts. So we place an abdominal drain, and that drain stays for the next 3 to 5 days, and as the patient recovers, it will be gradually removed. We close the abdomen. Now we have moved wherein we place, or our anesthesia team places, what is called as the tap catheters. These are small catheters which are put on the rectus sheath, and they provide continuous analgesia to the patient, and that ensures a pain-free recovery of the donors. The donor is extubated, or the donor wakes up from anesthesia in the operating room and is shifted to the ICU for monitoring. On the post-operative day 1 and post-operative day 2, the donor spends in the ICU for close monitoring, and usually by the end of day 2 or day 3 morning, they are shifted to the room. As they recover and gain more and more confidence, they become pain-free, they start eating normal diet, they're able to take care of themselves, they're able to walk, do their daily activities, and this happens by the next 4 to 5 days, they are ready for discharge. At the time of discharge, they are on bare minimum medication, something like antacid, paracetamol, just the minimum pain medications, and some multivitamins and supplements. The donor then follows up at 1 week, 2 weeks, 3 months, 6 months, and 1 year. They are not on any long-term medication. Remember friends, the liver will regenerate in as short as the next 6 weeks to 3 months to its actual volume pre-donation. The most important questions that all donors ask me, is it safe for me to donate? And the answer is, it is extremely safe. It is like any other surgical intervention being done on the human body. Extremely safe surgery. The risk to the donor in the literature and in my own experience is as low as 0.2 to 0.4%. All of them recover well. They go back to work in the next 2 to 3 weeks and live a long, healthy, productive life without any limitations, without any restriction. Thank you for watching this educational series on living donor liver transplantation. Do like, share, and subscribe to my channel. Thank you, friends.